This particular session is geared towards independent pharmacies. Just so everybody on the call is aware, the plan is to do a similar setup for folks in health systems and hospitals, and also hopefully do one for chain pharmacies as well. But again, we're going to record this beginning portion so people will have access to it. So the first thing you might be asking yourself, if you don't know, is who am I? So my name is Stuart Beatty. I've got a few different jobs. My background is I've been a faculty member at Ohio State at the College of Pharmacy for a number of years. And I teach and precept students and have a residency program there. But from a practitioner standpoint, I've practiced at a general internal medicine clinic, and I was the first pharmacist to start there. So that's working right alongside the physicians. And that's been instrumental in what I've been able to bring to the table as we've gone to OPA, because I've been able to see the struggles of what physicians have to deal with. I've been able to see value-based care firsthand, and I've been able to see where our pharmacy team has been able to implement itself and become an integral part of that care and continue to take that forward. So the past couple of years, what's happened is OPA has been able to get some of my time, and I've been able to help lead these provider status efforts for the state. So I'm happy to be here tonight with you. I like both aspects. I like the diversity, lots of different things going on to keep me busy. But I can tell you that the work that I do in the clinic as a practitioner lends itself extremely well to me helping lead OPA. And the stuff that I'm doing at OPA, I'm able to take back to Ohio State and to my clinic as well. So it's kind of the best of both worlds. So the first thing I wanted to go over just very briefly, just to kind of set the stage for where everything is just a little bit of a timeline for where things are with Ohio provider status. So I'm not sure everybody, obviously everybody hasn't been living and breathing this as much as me. So just so we can kind of set the stage for where things are. This whole thing started out, if you think about it, in 1776, the Declaration of Independence was signed. And in 1777, Ernie Boyd started actually lobbying to get pharmacist provider status in the state of Ohio. That's about how long this whole thing has been going on. But if we fast forward through that on a serious note, this has been going on for a number of years, but it really picked up steam in 2018. Senate Bill 265 was introduced by Senator Matt Dolan. This is Senator Dolan here. And then essentially what happened is it kind of laid low from the beginning. And then all of a sudden in December, it picked up steam and there was debate and testimony during the lame duck at the end of the year there. And then essentially what happened is just before leaving office, Governor Kasich signed Senate Bill 265 into law in January of 2019. So after that, January 2019, it was signed into law. In April of 2019, we have Governor DeWine had taken over. A couple big things that happened at that point. One was there was a House Finance Committee meeting. This is posted on the OPA website. If you haven't ever seen it, you should. You've got some of the key people around the state, some of the key payers in the Medicaid space getting up and talking about what they want pharmacists to do. And it's truly amazing part of the public record. In addition, in April of 2019, Governor DeWine announced that there would be reprocurement, which basically means all of the managed Medicaid organizations in the state, they all had to reapply for their jobs. So they were all going to have to go back and reapply to continue to be Medicaid providers in the state of Ohio. So moving forward, OPA started to work with some of those payers. I was kind of involved a little bit. Antonio and Ernie were really leading the cause there. In August of 2019, the decision was made coming out of the strategic planning, and with president at the time was Bridget Groves, that OPA should develop a task force and it should name a leader to that task force. And that's really where I started to dedicate more of my time to leading these efforts in August of 2019. Fast forward from there, we started to engage a lot with the various plans. We spent most of our time with the Medicaid managed care plans. And in April of 2020, so not even a year ago, United Healthcare was the first to announce that they had a provider status initiative in the state of Ohio where they were going to pay pharmacists. They started at 2 independent pharmacies in Northeast Ohio. Following shortly behind that in June, Buckeye Health Plan announced that they had an initiative. Buckeye Health Plan is working within 2 FQHCs in the state as well as with the health system. In August of that year, CareSource announced that they were launching. CareSource is at 2 independent pharmacies and a health system in the Dayton area. And then in October, Molina announced that they were having an initiative as well. And Molina is at 10 independent pharmacies around the state. So sometimes I think even myself, we lose track of the timeline of all of this and how quickly this has moved. It really has moved fast. It has moved extremely fast compared to other states. Within Ohio, we talk about how we are really leading the way across the country. Across the country, they really look to Ohio as a leader in what's happening with provider status. And it's a lot of what's happened with this timeline and the work that has been able to take place, specifically the work that's happened with OPA and setting the stage for what's happened with the Department of Medicaid. This is just a map of Ohio, and you can see where all these different pilots are taking place, the diversity. Again, I mentioned that we've got things happening in independent pharmacy, we've got things in the FQHC space, and we've got things in health systems. So a lot of diversity geographically and a lot of diversity across the different practice settings and in pharmacy. And again, I think that really bodes well for where things are moving forward. I can tell you, working closely with the plans, their eyes have been completely open as far as what pharmacists can do. This really started out with like, how do we kind of get off this PBM spectrum? How do we get out of the dispatch? How do we get off the front page of the paper? How do we start making the OPA and Antonio Chacha start tracking us down? I can tell you that quickly shifted once we started to have conversations about like, oh, wow, we never thought about utilizing pharmacists in that way. So there's obviously been a lot of talk about provider status and what pharmacists can do over the last 20 years. How do we start to re-engage with patients in a different way? How do we get away from the product? We don't need to get it completely away from the product, but how do we get to the point where we're not completely tied to the product and we can start to take care of our patients again? And that's what provider status is all about to us. Working with the Ohio Department of Medicaid, why are they so important? Well, the Ohio Department of Medicaid is who sets the rules for what pharmacists can do within provider status and how we can bill. And they set that for any Medicaid payer in the state. So in July of 2020, the Department of Medicaid released their first draft rules as far as what would happen around pharmacist provider status. OPA provided some comments all the way back in July. Those were only available for 10 days to provide comment, and we provided a lot of comment with them. We were trying to work with the Department of Medicaid very closely over the summer and in the fall to let them know what our thoughts were on the rules to help clean those up. What happened then is in November, the department released the rules and they were available for comment for 30 days. Again, OPA worked closely, or we tried to work closely with the department to let them know our concerns. We tried to set up some alternatives. We tried to talk through some things with them to try to get the rules where we wanted them. In January of 2021, those rules were finalized and posted, and pharmacists can now obtain that Medicaid ID number. And that's what we're going to talk about here tonight. Just so you know, OPA, as Antonio mentioned, we will continue to work and we will continue to work for you guys to broaden and open up these rules. These rules are not necessarily where we think they need to be. There are restrictions in place to try to keep this at least somewhat at bay and not open it up for every pharmacist to bill all the time across the state. We kind of understand where they're coming from there, but we think there's just way too many restrictions, especially for community pharmacists and especially for those of you that are in independent settings. We've really tried to talk a lot with the Department of Medicaid for what you guys bring to the table, for the access point that you guys have for patients. These are often in rural or they're in underserved communities. We understand that. We've told them that. These are people that did not have access to healthcare and they're missing a completely reliable, accessible healthcare professional right there. So we will continue to work on your behalf for that. We'll continue to try to broaden these rules out. As far as the rules themselves, you can find them if you click on this link. And I think if I do that, we'll see what happens. You can then bring that up. My guess is I'm not sharing that. So give me just a second here and I'll move this over to that screen. Okay, hopefully you guys can see this. These are the actual rules that are finalized that went into effect on January the 17th. And this goes through what the payment is. This is only 3 pages long. The big things that we want to point out here, the service is rendered, it has to be within scope of practice, and we all understand that. But if we come down here, the pharmacist has to obtain, I'm hoping this shows up if I highlight it, the pharmacist has to obtain an order issued by a practitioner having prescriptive authority, and you have to maintain that. So you have to get an order, just like what a prescription would be, from a physician in order to get to bill Medicaid for these services that we're going to talk through. Again, this is one of the big limitations. We understand how much of a limitation this is, but this is where the rules are right now. So you are going to need to get an order from those physicians. In addition, you have to have what it is saying here is you have to have a collaborative practice or a consulting agreement with the prescribing practitioner. So not only do you have to have a CPA in place, you also have to get an order from them in order to actually bill for that service. That is restrictive. We have tried to tell them that's restrictive. That's exactly what we're talking about when we're talking about wanting to open these up and broaden these up. But if you want to do this in the future, these are the rules that you're going to have to follow for this time. Those are the biggest things that are here. Again, if you want to look through those rules, you can click on that link, but we wanted to make sure that we pointed that out tonight. Okay. Now, let's see if I can go back to this screen. Maybe. And the other thing, the next thing I guess I wanted to go through is I wanted to take you actually, hopefully all of you got an email from OPA taking you to a website. Hopefully you can see this. This is the OPA website on provider status. If there are any updates you need, then we want you to go here. What we have, you can see down here, there are various things, updates, provider status log, which is something that Miriam has been doing, highlighting what's happening in independent pharmacies, which is amazing. Different media things, but if you go to this resource tab, this is where you need to go as a pharmacist, and we put these tip sheets and things together so it's as easy as possible for you to go and do these things. The first thing you're going to need to do is you're going to need to go to this NPI application guide. If you do not have an NPI number, you're going to need to get an NPI number first. So if you click on that, you're going to get a screen that looks like this. This comes directly from the Center of Medicare and Medicaid Services. This will take less than 5 minutes to fill out. You can fill this sheet out and you can have an NPI number within a week. An NPI number is a national provider identification. That's what all providers need, and that's what helps link payment back to you as an individual practitioner. So this is the first step if you have not done that. Then if you go back to this page, the next thing you'll need to do is you'll need to go to the steps to obtain a Medicaid provider ID number, which is this screen. So again, we put together some screenshots for you. This has only been live since January the 17th, so this is new. We've updated this sheet already once. If there's feedback that you guys have, please give it to us and we can update this again. Notice that the first thing it says on here, this is the question that's come up more than anything. You will need to submit a W-9 form with your own individual Social Security number on it in order to get an Ohio Medicaid ID number. As you go through this process and you go through these screenshots, this is about 15 pages long. It's going to have you do various things. One of the things it's going to ask you to do is to provide either your Social Security number or an employee tax ID number. I'm talking to independent pharmacists right now, and I get that. What you need to do is you need to put in your individual Social Security number in order to get a Medicaid ID number. I asked this directly to the state. If you want to go and register your independent pharmacy, then you can do that separately and you can enter your employee ID number. But if you want a Medicaid ID number yourself, you need to enter your own Social Security number and need to enter your own W-9 form. So again, if you go through these 15 steps to get this Medicaid ID number, it'll take you less than 1 to 2 weeks and you will have your own Medicaid ID number. You can follow right along with this screen As you go through here, hopefully it shows you step by step what you need to do. And any place where there's any confusion, we've talked to Medicaid. They worked really closely on putting these things together for us, and they've given us tips to help this whole process along. So again, you can go through here, look at this on your own. You can see this is where it's bolded. You have to enter your personal Social Security number. You do have to have your NPI here, and you do have to have your pharmacy license number. So that's what you're going to have when you get to this particular screen, which is about 7 or 8 pages in. Okay. You continue to go down through here. A lot of this information, again, it should be pretty straightforward. You can see this is only an 8-page document to go through. You submit that with a signed IRS W-9 form. Within 2 weeks, you should get a Medicaid ID number. So once you have your Medicaid ID number, you've got your Medicaid ID number. What does that mean? Well, if you have questions about any of that, the next form is this page that we put together, which is frequently asked questions. So this, again, we worked very closely with the Department of Medicaid on putting this together. We tried to think about any question you may have up front, and we tried to get that answered. So the first thing is it talks about what's the difference between fee-for-service and managed care. Once you have a Medicaid ID number, if you are meeting the rules, which the biggest rules we have to meet here are, again, you have a collaborative practice in place, and you've got an order from a physician, you can start to bill on the medical side fee-for-service patients, which are straight up Medicaid patients. They have Ohio Medicaid. I realize that that's about 10% of the population, so that's fewer and fewer people, but still they really opens up the door to allow you to start billing people right away. As you go down through here, this will tell you how to enroll, and then you can get to this page, and these links right here are for Buckeye Health Plan, CareSource, and Molina, and there will be one within the week for United Healthcare Community Plan. Once you have your ID number, you can go and register with those particular plans. And again, if you are meeting the rules, you can start to bill Buckeye, CareSource, or Molina patients if you have collaborative practice in place, and if you have that order in place, you can bill those patients. So this is really big. These plans have opened this up quickly. The other thing that's exciting is this is not just for Medicaid. This is also for dual eligible patients. So if you are going in and enrolling with CareSource and with Buckeye Health Plan, you can enroll not only for their Medicaid patients, but also for their MyCare patients. So you'll be able to do that for those dual eligibles. This is getting us into the Medicare space where we didn't even know we were going to have the opportunity to get in the Medicare space. So we want to encourage you to do that with your patients as much as you can. A nice thing that the state has done for us, this talks about what do I need to do to get credentialed. Right now, the only thing you need is you need that Medicaid ID number. The state is moving to an online universal credentialing platform. They're going to be building that out throughout the spring and early summer. So they realized the timeline of that, it didn't make a whole lot of sense to have pharmacists have to wait or to have them enter something now and then have to redo it over the summer. So what they've done is they've basically said if pharmacists get their Medicaid ID number, all of those managed care plans are not going to make you get any additional credentialing. You can go in and use your Medicaid ID number to go ahead and contract out with those plans. So that's a really big step, and that's a really big thing that the state has helped us do. Okay, as we continue to go down here, this has some additional information about consult agreements. You do need to follow the consult agreement laws. If you've never done a consult agreement, we can maybe go through that later. There are some great templates on the OPA webpage that can help you get started. And we can maybe talk through some tips and some various things to help you think down that path so you can start to work towards collaborative practice. This also talks about the order that's there and what needs to be on that order. The order is good for 1 year. So essentially they're treating the order like a prescription. It's good from 1 year from the date that it is written, and then it will need to be reissued every year. Again, this is something that we've tried to tell the Department of Medicaid does not make a whole lot of sense, because you're saying that we have to be under collaborative practice. The collaborative practice laws say that that physician, or now that nurse practitioner or physician's assistant, has entered into collaborative practice for their group of patients, for me as a pharmacist to take care of those group of patients, And you're saying the law is that that is good for 2 years. This rule is saying that you have to have an order that's only good for 1 year. No matter how many times we have told them that, they have come back with the order is good for 1 year. So where things stand as of now is that order would only be good from 1 year from the date that it is written. And that's where that stands. One of the big questions is, what do we do for billing? Pharmacists are not used to doing billing codes at all. So this is the list of codes, and you can spend some time looking through this on your own, or if we want to come back to this later, we can come back to it later, but this is the list of codes that as pharmacists, we are able to bill at this time. I will let you know, these are similar codes to what a physician bills when you go see them in the practice. So these are called E&M codes, or evaluation and management codes for the most part. That's the 99202, 99203, 99211, 212, and 213. That's probably 75% of the codes that physicians are going to bill when they see patients. Unfortunately, at this time, there are higher level codes, which are higher levels of service that reimburse more. Those are 99214 and 215. Right now, for some reason, the department is saying that pharmacists can't bill those. Again, we're going to continue to work with them and say, why exactly are we restricting that for our patients that are on the highest number of medications that are the most complex? But as of now, this is what you can do. Another thing that is nice, though, that I'll point out below that is they have included some of these new telemedicine codes. So the telephone and e-consult codes that are there, they are allowing pharmacists to bill for those. So even if you're in an independent pharmacy, you can see these patients face to face. You can also call patients in between their appointments, in between when they would come in to see you to fill a prescription. You can call them at home, and you have a mechanism to actually bill and receive some reimbursement for that. So that's a pretty exciting step that they've included those telemedicine codes in there. Just moving on to finish this out, can you bill an MTM and can you bill one of the codes above? You should not bill those on the same day. You can still bill MTM separately, and you can still bill these codes separately, but you should not bill an MTM for a comprehensive med review and, let's say, a 99213 on the same day. What you can do is you can take the time that you're spending on that CMR and you could wrap that all into one payment for your time-based code of a 99213. You should not submit those bills at the same time. That could be construed as double billing for the same service, and we do not want to go down that path. Okay, and I think that that is essentially the questions that would pertain to you as independent pharmacists. I know I went through this fast, and I know that there's going to be lots of questions on the back end. I want to make sure I get to those, but I wanted to go through this document and show you what was there and show you how to find it. So again, you can find that. You can find all three of these on the OPA webpage, and you come over here to provider status. Once you're on provider status, you go over here to resources. You've got a guide to the NPI application. You've got a guide to how to obtain your Medicaid ID number, and you've got a guide to those frequently asked questions. If there are other questions, you can feel free to contact me. My email address, I think, has been sent to all of you already. If not, we can get that out. The other thing that we would ask you to do, and it's at the bottom of that FAQ sheet as well, if you have not already filled it out, you can fill out this survey here, which is going to tell us what types of services does your pharmacy currently provide. When it comes to these various programs and these pilot programs, these implementation programs we talked about, I want it to be clear that OPA did not select those pharmacies. The plans selected those pharmacies based on their own internal data analytics. What OPA has been doing, what my team has been doing, is we've been trying to support those pharmacies and work extremely closely with them, but we did not select those pharmacies. If a plan comes to us and says they want to know what pharmacies are available, what we have done is we have given them the results of this survey that was sent out the first time a year ago, but people have been filling it out and we've been trying to keep it up to date. So that information has been shared with the plans, but ultimately it's been up to the plans to decide where they want to go with those pilot programs. I will say, even though this is being opened up, the plans do have the ability to work outside that collaborative practice agreement if they want to. And in some of the current pilot programs, they are working outside of those rules that we went over, and they are paying pharmacists for that. If that's going to continue, I don't exactly know. I know that the plans are really bought in and they really do buy into what we are doing. But when it comes to who they're going to actually pay and how quickly they're going to open all of that up, I don't exactly know the answer to that. But if you actually fill this survey out, that's how they would get that information. And they are all looking to expand those pilot programs currently as we speak. So I realized I went over a lot of information and I went over a lot of information really, really quickly.